You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 7th, 2021. This week, COVID, TAVR versus SAVR, Subcutaneous ICD, Sglt2 inhibition, and physician moms. First up, 3 quick comments on COVID. The rates of infection continue to decrease in the US, EU, UK, and Canada. As a doctor, I'm an observer of human nature, and the most interesting aspect of the pandemic now is the tension on returning to normal after vaccination. I see this tension on social media, in the hospital, and out there in the neighborhoods. The CDC has released new guidelines on not needing to wear masks outdoors, yet some communities kept mask mandates in place. Some fully vaccinated docs still wear N95s and eye shields around the hospital. I know it's been a very hard 16 months, and I think it's going to take time. I keep going back to those messenger RNA Kaplan-Meier curves and the Israel real-world evidence. We just aren't accustomed to therapeutics this good, and I'm really persuaded and positive on the vaccines. Second comment, India and Brazil. Gosh, I hope we're surging vaccines to these countries, and my thoughts are with my colleagues there. Third comment, Lancet Diabetes published a pretty important observational study from UK researchers. The first author is Dr. Min Gao, in which they studied the association of BMI and bad COVID-19 outcomes in Public Health England's database. Now, we all know that obesity is a risk factor for severe COVID. That's not new, but this paper found a linear association beginning at even slightly overweight BMIs of greater than 23. Now, linear meaning that the risk is higher at 24 than 23, higher at 25 than 24. The paper's open access, and go look at Figure 1. It depicts a gradually rising hazard ratio from a BMI of about 23 to 24. And importantly, this association was not attributable to excess risks from diabetes, and the BMI was a greater risk for younger people than for older people, and for black people compared with white people. Now, I realize this is a totally anecdotal observation, but it's what I've seen here. It's just so rare to see normal weight young people in ICUs with COVID. And I can't help but think there's something very curious about how this virus interacts with cardiometabolic effects of being overweight. Now, of course, the implication of this important study is that overweight and obesity are utterly modifiable risk factors. Second topic is transcatheter aortic valve replacement, TAVR versus SAVR, and the treatment of patients with aortic stenosis. Here we go again. Last month, the European Heart Journal and JACC published the newly updated Valve Academic Research Consortium 3. These are VARC-3, VARC-3 definitions and endpoints proposed for transcatheter and surgical aortic valve replacement research. The 23 authors, 20 of whom have been authors on TAVR trials, wrote that the aim of these new definitions were to, quote, add more granularity and a patient focus to a rapidly evolving field. Journalist Patrice Wendling has a superb news recap on this important change in definitions. In the third paragraph of her story, she quotes the first author, Dr. Philippe Generoux, who said, the main change in VARC-3 is really that we try to define not only procedural outcomes, but also more the long-term outcomes mainly based on the patient. So quality of life, bioprosthetic valve function, how we define valve failure, and also the need for rehospitalization. Now, it's a long document. It details each of the important outcomes in future research. of these techniques, things like mortality and neurologic events and hospitalizations and bleeding, new conduction disturbances and arrhythmia, vascular complications, myocardial infarction and valve dysfunction, including the issue of valve thrombosis. Now, these sound mundane, right? These are legitimate outcomes, no problem. Well, the new document raised the ire of some cardiovascular surgeons who pointed out some important issues that I think are worthy of mention. First issue, VARC-3 now defines hospitalization or rehospitalization as any admission to an inpatient unit or hospital ward for greater than 24 hours. Recall that all the TAVR and SAVR trials except Partner 3 had as their primary efficacy endpoint stroke and death. These are really good primary endpoints, hard endpoints. But inexplicably, Partner 3 added rehospitalization, and of course, this turned out higher in the SAVR arm. Patients who have surgery will have more early postoperative rehospitalizations. While on social media, cardiovascular surgeon Victor Dayan from Uruguay rightly countered that this will bias trials against surgical aortic valve replacement. Now, I think it would be fine to use hospital admissions, but you need a blanking period of some weeks to months. All right, the second issue with this new document is that VARC-3 redefines the previously vague definition of valve thrombosis to include, quote, clinically significant valve thrombosis, which again sounds reasonable. But Dr. Dayan points out that now a thrombus is not a thrombus unless it is associated with a clinical event or a severe hemodynamic deterioration. He points out that this change would erase the worrisome finding in the 2-year results of the Partner 3 trial that found a 3.7-fold higher rate of valve thrombosis in the TAVR arm. The third issue, VARC-3 also changed the definition of peri-procedural MI to the definition used in the controversial XL trial of drug-eluting stents versus surgery for left main disease. The old VARC-2 definition required clinical findings and biomarkers. VARC-3 has now changed to the modified SKY definition, which uses biomarkers and is procedurally agnostic. The biomarker agnostic issue is a problem because surgery is always going to release more enzymes than a procedure. Now, the fourth issue is the meta issue. Dayan and others point out that 20 of the 23 authors of the VARC-3 consensus are trial authors, and they feel that, like scientists, can't be the judge, jury, and attorney for the evaluation of science. Another point made was that only 3 of the 23 committee members of VARC-3 were surgeons. And although the American College of Physicians recommends guideline committee members with moderate or high-level conflicts of interest recuse themselves from authorship, one VARC-3 author has received more than $2 million in fees from industry in the past 4 to 5 years. Now, my comments on this is, I am sympathetic to all of these concerns. Hospitalization should not be a primary endpoint in these trials. Subclinical thrombosis enough to limit leaflet mobility seems like an important issue. Myocardial infarction definitions that includes clinical symptoms is a completely fair debate, and it hardly needs saying that conflict of interest, both intellectual and financial, are relevant. And I've said this many times before in this podcast. Guideline and consensus documents should include far more neutral judges and far fewer content experts. Finally, indeed, TAVR has been a huge advance, but we still need to keep studying this procedure fairly, especially as it is extended to lower-risk, younger patients. Now, a second TAVR study and story I want to mention is TAVR Availability. This podcast is acutely aware of and concerned with disparities in healthcare outcomes and variation in care. Patrice Wendling has another nicely written report on a related TAVR study that was presented at the SKY meeting. Using Medicare claims data, UPenn investigators identified more than 550 new TAVR programs, and their findings suggest that there's less use of TAVR in poorer communities. Okay, the top line specifics were that 98% of new TAVR programs were established in metropolitan areas, and about half of these were started in areas with pre-existing TAVR programs. That finding, therefore, increases the number of programs but does not necessarily increase the geographic availability of this procedure. Now, they used a lot of demographic data and concluded that the increased number of TAVR programs found during the study period did not translate to increased access to TAVR. They concluded wealthy, more privileged patients had more access to TAVR by virtue of the hospitals that served them. Okay, this is a tricky topic, but I think worth thinking about. Yes, ideally, we should have absolutely equal care in all parts of the country. But we don't have a national healthcare system like in the UK here in the US. That poor areas of the US don't have the same access is one of the trade-offs of our profit-driven system. Always think about trade-offs. Not having skilled TAVR operators in poor areas will deny poor patients with high surgical risk the ability to have this transformative procedure, and that's a problem. But let's also move past first-order thinking and consider that simply putting out more TAVR programs with low-volume procedure numbers isn't free of issues either. I mean, I've seen some electrophysiology in rural areas, and sometimes it isn't ideal. TAVR, like so many of these new procedures, requires big teams of multiple specialists who do lots of procedures. Emphasis on lots. Volume matters. You can start a TAVR program in a rural or poor area, but if the team doesn't do enough procedures, the patients there aren't any better served. I remain drawn to the Canadian system in which few centers do tons of procedures. Even though this requires folks to travel longer distances, wouldn't it be better to do that than have a procedure done at a low-volume center? Next topic is the subcutaneous ICD. At the European Heart Rhythm Meeting, Dr. Pierre Lambiase presented 5-year data from the effortless registry of the SICD. Briefly, the SICD, or subcutaneous ICD, is a device placed in the left lateral chest approximately at the mid-axillary line. The one lead is tunneled just outside the chest wall to the sternum, and then it takes a right northward turn and sits parallel to the sternum outside the chest. The idea of having an extrathoracic device with no transvenous lead is that you can sense and defibrillate VF without the downside of venous lead complications like infection, lead failure, tricuspid regurg, and venous obstruction. The downside, of course, is that having no lead in the heart means no pacing, no painless anti-tachycardia pacing of VT, and serious challenges to sensing the atrial and ventricular signals. Now, remember the rule. Science tells us what we can do, trials tell us what we should do, and registries tell us what we are actually doing. So the industry-sponsored effortless registry enrolled about 980 patients from multiple centers in Europe and New Zealand, and the main purpose was to document the complication rate, incidence of inappropriate therapy, and the extrapolated cost associated with the SICD system. The registry started way back in 2012 with early generation devices. That's an important point. Now, the last report of this registry was published in JACC in 2017. Steve Stiles has excellent news coverage of the abstract presentation on the heart.org Medscape Cardiology website. The results of this registry are sobering. But before I tell you the results, remember this was not a mandatory registry. This was an industry-sponsored registry in which patients were enrolled at the discretion of the investigators. Now, you'd expect that to be the best-case scenario because investigators aren't going to put their big disasters in these studies. At 5 years, the overall complication rate was 18.4%. Nearly 1 in 5 patients had a complication. Overall, there were 328 inappropriate episodes in 155 patients. That's about 16% of patients. The 5-year inappropriate shock rate was 16.9%. The majority were due to oversensing. Only a small percent of inappropriate shocks were due to atrial fib. Now, for reference and context here, I went to some other studies and found an inappropriate shock rate of approximately 3% in the MADE-IT RIT and pain-free SST studies of the transvenous ICD. As for appropriate shocks, these occurred in about 16% of patients, including a substantial portion of whom had monomorphic VT that may have been terminated painlessly with ATP if they had had a transvenous device. Now, one important caveat regarding inappropriate shocks in this registry was that the SICDs were implanted before the advent of what Boston Scientific calls the, quote, smart pass filter, which reduces but does not eliminate T-wave oversensing. Still, though, I disagree with one of the presenter's concluding comments. He wrote in his slide, quote, in this device registry, complications primarily occurred in the first year but remained low through 5 years. I don't consider a complication rate of 1 in 5 low. And really, things haven't gotten better for the SICD. We now have 2 Class 1 FDA recalls for this device, one for the only lead that's available and the other for an older generation generator. You may already know this, but Jack EP has published a point-counterpoint argument on the SICD from Drs. Bogdan Inaki and I versus Drs. Raul Weiss and Emil Daoud on pausing implantation of this device in lieu of the well-studied transvenous ICD. I will link to this article and encourage you to read the arguments on both sides of this debate. Our side includes also a critical appraisal of the Praetorian trial of Subcutaneous ICD versus transvenous ICD, and that trial had some really serious limitations. Next topic is some very big news on the Sglt2 inhibition front. FDA has approved dapagliflozin to reduce the risk for kidney function decline, kidney failure, CV death, and heart failure hospitalizations in patients with chronic kidney disease, CKD. This is now the 3rd indication for this drug. It was approved in 2014 for use in patients with type 2 diabetes and in 2020 for patients with heart failure with reduced ejection fraction. The approval in patients with CKD was based on the DAPA-CKD trial. Recall that DAPA-CKD enrolled about 4,300 patients with chronic kidney disease. Average eGFR was 43 to dapagliflozin versus placebo. This was published in the New England Journal of Medicine. The primary outcome was a composite of a sustained decline in GFR of at least 50%, end-stage kidney disease, or death from renal or cardiovascular causes. The trial was terminated early because of efficacy. A primary endpoint event occurred in 9.2% in the DAPA arm versus 14.5% in the placebo arm, yielding a hazard ratio of 0.61 with confidence intervals ranging from 0.51 to 0.72. This absolute risk reduction of 5.3% puts it in the highest tier of preventive therapies, even greater than the 4.7% absolute risk reduction seen in the Paradigm heart failure sacubitril valsartan versus enalapril trial in heart failure with reduced ejection fraction. And this was not one of those stories where the composite endpoint was driven by soft outcomes. No, dapagliflozin treatment also cut all-cause mortality by a statistically significant relative reduction of 31%. I consider this huge news because there are a bunch of patients in cardiac and arrhythmia clinics with CKD. And keep in mind that only 10% of patients in DAPA-CKD had heart failure. Final topic today is a feature story. Dr. Michelle O'Donoghue has an excellent video blog about the many challenges of being a physician mom. It's up on the heart.org Medscape Cardiology, and it's definitely worth a listen. 2 of her key points are A, acknowledging that working moms don't want to be treated differently, but they do need time to, say, break away from rounds at times. And B, better communications about resources available to doctor moms. My daughter isn't a doctor, but she is in the healthcare field, and I see these challenges firsthand. This is a tension that male doctors can't fully appreciate, all the more reason to take a listen to this video blog and, of course, think about what Dr. O'Donoghue says. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, friends, please, if you like this podcast, please take the time to give us a rating or write us a review, as that helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.